Welcome back, everyone. The next session is a symposium focused on optimizing diabetes care. So I'm pleased to welcome the distinguished chairpersons, Dr. KVC Janaka and Dr. Durga Manohari on stage.
The first symposium for the day is on optimizing diabetes care. We'll be having 3 20-minute lectures and we'll be taking questions at the end. So we'll start with the first lecture. I will introduce the first speaker, Dr. Pankaj Shah, MD, DM Endocrinology. He's an endocrinologist, Mayo Clinic, Rochester. He has his medical training at University of Delhi, India, Institute of Medical Science, India. And he did his residency fellowship, Creighton University and Mayo Clinic, USA. He is the chair of Hospital Endocrinology and Diabetes Unit and chair of the Transplant Endocrinology. His area of interest are hypoglycemia in people with diabetes, transplant endocrinology, diabetes and hyperglycemia in complex clinical situations. Sir, may I invite you to the stage?
Good morning. Thank you. My mandate is to talk about in-ward hyperglycemia management. This is the talk outline. We'll briefly talk about summary of evidence and guidelines of management of in-ward hyperglycemia, and then I'll proceed with certain questions. Are glucose targets the same for people without and with diabetes when they are in ward? What about the sliding scale insulin? What about carbohydrate counting to determine the meal dose? What about non-insulin therapies while in hospital? What about continuous glucose monitoring and meter and insulin pump while in hospital? Let's start with summary of evidence. We know that illness and the treatment of illness causes hyperglycemia through various mechanisms as has been listed here. This next slide shows that as the average glucose concentration increases in hospital, overall mortality goes up such that if average glucose is more than 300, the overall mortality may be about 7 times higher than those whose glucose is about 100 milligram per deciliter. This is true for people without diabetes and with diabetes both. So, hyperglycemia through various mechanisms as have been listed here, decreasing immune function, fluid shifts, electrolyte fluxes, etc., worsens wound healing and causes end organ damage. Bottom line is that high glucose in hospital is bad. What about the other end? We know that higher glucose increases mortality. However, lower glucose also increases mortality. So if the average glucose is less than 70 milligram per deciliter, there is 5 times higher risk of mortality. So even low glucose in hospital is bad. Now the question is, if high glucose is bad in hospital, does treating high glucose prevent outcomes? This is the pivotal trial, the DIGAMI study, the diabetes mellitus insulin glucose infusion studies in acute MI, in which the standard patients of acute MI were taken and randomized into 2 groups, one which received insulin glucose infusion for first 24 hours and then started subcutaneous insulin, and others were given insulin only if clinically indicated at that time. And this is what happened. After 24 hours, the glucose in the intervention group was about 40 points lower, and at the time of dismissal, about 15 points lower than the control group. And this is what happened on 5-year follow-up. As you can see, there was a 30% reduction in mortality by better glucose control while in hospital for about 7 to 10 days only. Substantial reduction in mortality over a period of follow-up. Actually, if followed up beyond 20-25 years, the mortality is lower in those who were controlled well when they were in hospital on a randomized controlled trial, such that by controlling glucose well while in hospital, on an average, they gained about 2.5 years of life. So I can convince you that improving glucose helps, but we talked about lower glucose increases risk of mortality as well. This is a network meta-analysis of various studies conducted in this area, and as you can see that there is higher chances of hypoglycemia if the target glucose is less than 140 milligram per deciliter. The least chances when target glucose is more than 180, of course. This is about infection. The risk of infection is higher if target glucose is above 180 milligram per deciliter. And this is about hospital mortality. Hospital mortality is lowest when glucose concentration is between 140. Targeted glucose concentration is between 140 to 180 milligram per deciliter. And that happens to be the sweet spot. And that is the reason why the hospital target glucose is 140 to 180 milligram per deciliter. How we can achieve this? Well, some things are very obvious. If the patient comes with critical illness, whether medical illness or surgical illness, we use intravenous insulin. If the person comes with severe diabetic ketoacidosis or HHS, we need intravenous insulin. If mild to moderate DKA, we may use subcutaneous insulin. If it fails, we can go to intravenous insulin. After all this intravenous insulin, we have to transition them to subcutaneous insulin. We can transition to basal insulin plus correction insulin as needed, or basal plus bolus plus correction insulin, otherwise called multiple daily dose insulin plan. If the basal plus correction does not work, we may want to go to multiple daily insulin dose plan. And if the person with type 1 diabetes is admitted, we keep target glucose of 140 to 180 milligram per deciliter and always use basal bolus plan and don't go to other plans. If it is type 2 diabetes with severe hyperglycemia, glucose more than 300 milligram per deciliter, or if the patient is already using large doses of insulin, we use basal bolus insulin plan. If on the other end is moderate hyperglycemia, 200 to 300 milligram per deciliter, and the total daily dose is not very high, we use basal plus correction, and if that doesn't work, we can go to multiple daily insulin plan. And there is mild hyperglycemia, the glucose is still below 200 milligram per deciliter, taking non-insulin agents, but 2 or less number of doses. We can use low dose basal insulin or non-insulin anti-diabetic agents and plus correction, and if not, we can go to basal. If not, we can go to multiple daily doses of insulin. So this is the overall guidance of management in ward in patients, in individuals with hyperglycemia. Let's go to specific questions. The first question that I am addressing, are glucose targets same for people without and with diabetes in hospital? And there is a very interesting study that I would want to bring it to you. This is the effect of liberal approach to glucose control in critically ill patients with type 2 diabetes. And it is a multi-center study in Australia and New Zealand. Type 2 diabetes who were expected to be in ICU for 3 days or more were recruited for this study and randomized into 2 groups. One where the glucose target was 180 to 50 milligram per deciliter, and other, the standard glucose target about 110 to 180 milligram per deciliter. The primary outcome was incidences of hypoglycemia, and secondary outcomes were glucose metrics, overall glucose control, and stuff like that. And about 1/4 of the patients who fitted in those criteria were ultimately recruited, and several of them not recruited for various reasons, as the paper tells us. So those who we wanted to keep a higher target had higher glucose concentration than those whose glucose target was lower, as was expected. However, as you can see here, only about 45% of people whose target was 180 to 250 milligram per deciliter was in that range. 20% was higher, 30% was lower. On the other hand, those who had target 110 to 180 milligram per deciliter, about 50% were in that range. Rest of them were higher mostly. What happened at the end of the study? Those who were having a higher target of glucose had significantly less numbers of hypoglycemia and number of multiple episodes of hypoglycemia. This study shows that if glucose target is kept higher in people with well-established diabetes, that they will have less hypoglycemia if we keep the glucose target higher. And there was no difference in death at 90 days, hospital ICU stay, days in hospital, ICU-free survival, infections, etc. There was no difference in other outcomes. That would mean that we definitely need more trials for this, but it may be reasonably okay to consider permissive hyperglycemia in those who have established diabetes. For example, if it's non-diabetic, we may want to keep a target to 140 to 180 or 140 to 200 milligram per deciliter. But is poorly controlled diabetes when at hospital admitted to the ward and glucose average hemoglobin A1C is above 7%, we may want to give a higher target, 140 to 250 milligram per deciliter, for example, in these patients. Well, the least we, even if we don't want to do that, the least we can do is to reduce the dose of insulin to as little as possible so that we can control glucose well and reduce the risks of hypoglycemia while in hospital. Coming to the next question, what on earth is this sliding scale insulin? Well, there is one scale which we call correction scale of insulin, is when we measure glucose before meal and give insulin per a scale before meal, dose given before meal. So that we call correction scale insulin. And then there is a supplemental scale insulin in which you want to measure the glucose before meal and we want to add that extra insulin to the meal dose taken before meal. And then there is this good old sliding scale insulin. Glucose is measured some time of the day. Nurse looks at the list and gives the injection right there and then, and nothing to do with meal at any time, day or night. That is the so-called sliding scale insulin, of course. That is the wrong answer for postgraduates and medical students. Sliding scale insulin is never the correct answer of any question ever. So in analysis of various studies and meta-analysis about sliding scale insulin, it appears that sliding scale insulin is associated possibly in cohort study, shown a longer hospital stay by 3 to 4 days. There is lower risk of hypoglycemia, about half or 1/4 of what is in scheduled insulin doses, but much higher mean glucose is shown by RCT, by cohort study, and overall about 25 milligram per deciliter higher glucose concentrations if sliding scale insulin alone is used as a treatment plan. So what do we do? If there is no prior history of diabetes, glucose is more than 140 milligram per deciliter, we initially start a correction dose of insulin. We give before meals, check before meal, give the dose based on the glucose before meal. If the glucose is higher than 180 milligram per deciliter on 2 separate occasions, then we schedule insulin doses and move to multiple daily insulin plan. If the patient has already established diabetes, which is with diet or non-insulin agents, and admission glucose is less than 180 milligram per deciliter, we may want to use correctional only. If it is more than 180 milligram per deciliter, we want to give the scheduled doses. If it is insulin-treated patients, we continue a scheduled insulin regimen and modified for nutritional status and illness, etc. So this, I'll give you a few examples. A 56-year-old man with pneumonia admitted last evening at 9 p.m. Glucose at the admission was 189 milligram per deciliter. Fasting glucose is 160 milligram per deciliter. Noon glucose is 208 milligram per deciliter. It's non-diabetic person. BMI is 32.4. We start correction scale for 2 days. We have multiple scales that we use in our institution. These are various scales that exist in we pick up the moderate scale or correction scale number 2, and we use this correction scale before meals. And if it continues for a couple of days, we schedule the insulin dosage and just don't give only correction as we started. Another example, a 56-year-old man, this time admitted with non-ST elevation MI, same glucose numbers, everything else non-diabetic, but BMI is less here. And we start correction scale insulin for a couple of days. And here we are using a lower scale, not a higher scale, because BMI is less and patient has an MI. Why? Because they are either at a higher risk of hypoglycemia or at higher risk of complications from hypoglycemia. And who are they? These are people who are older, have lower BMI, type 1 diabetes, pancreatitis, organ failure, Addison disease or pituitary disease, those who have recent cerebrovascular accident, unstable angina, congestive heart failure, malignancies, infections, and prior episodes of hypoglycemia, unawareness, or large insulin doses used. So these are the people who are more likely to develop hypoglycemia, except the last the total insulin daily dose being high. All others, we use small doses of insulin to begin with, and we may have to go up if they don't work down the line, but we don't want to start with a larger dose of insulin. Moving on, similar story, but this time established diabetes person, admitting glucose 389, fasting glucose 299, noon glucose is 308 milligram per deciliter. Patient is on metformin and sitagliptin at home. Hemoglobin A1c is 7.6%. So here, high glucose, we want to schedule an insulin dose. We use 20 units of glargine. Why? It's 80 kilo person, 80 times 0.5. That is the total daily insulin requirement, half of which is basal. So 20 units of glargine given once a day. Rest of it given as meal doses. So rest of the 20 units I'm dividing into 6, 6 and 6 for the other 3 meals. And that is how I'm getting the meal doses. And I'm giving moderate intensity, the relatively higher correction scale insulin as has been shown here. Now, similar story again, this time with acute MI and lower BMI. Hemoglobin A1c is also 7.6, but here I want to start with a smaller dose of scheduled insulin, half of what we started in the previous one. Rather than 0.5 unit per kilogram body weight, with 0.25 unit per kilogram body weight divided into 2. So I'm starting only with 9 or 10 units of glargine and 3 units of rapid acting insulin before meal, and I'm using small dose of correction added to the meal doses at the time of meal doses based on glucose check before the meal. On the other hand, the patient is already on insulin at home. Patient is taking 16 units of insulin at bedtime. Hemoglobin A1c is very well controlled. We continue glargine, give some correction scale only along with meals, nothing else. The patient is taking 36 units of glargine with aspart, the rapid acting insulin, 3 times a day, about 10, 12, 14 units. So substantial insulin doses. Now I want to use same dose of glargine at home, and we give supplemental scale with meal, but meal doses as well. And now somebody has taken large dose of glargine, but is using very small doses of rapid acting insulin, 2, 3, 4 units, once or twice a day, based on if my blood sugar is high, I take it or not. Then I don't give this whole dose of glargine. I give about 25-30% lower dose of glargine and give supplemental scale insulin. So this is the strategy that we follow while the patient is hospitalized. But what if the patient can eat, but we don't know how much is going to eat, and is going to eat whether going to throw up or not going to throw up? In that situation, we use carbohydrate counting. And in carbohydrate counting and meta-analysis, not a lot of studies, actually 3 studies have shown that possibly less episodes of hypoglycemia, but no difference in average glucose or overall glucose control, etc. So what do? We find out whether it is appropriate to use carbohydrate counting in the patient in the hospital. These are patients who are on basal bolus regimen and uncertain to know how much they are going to eat. They're not meant for correction scale only or NPHUs, or those who are snacking all the time. Then that's not a good plan for them. If that's the case, you want to find out the patient is using carbohydrate counting at home. And if the patient is using carbohydrate counting at home, then we want to use the home carbohydrate insulin ratio, insulin carbohydrate ratio at home. If not, we want to calculate it, and one of the formula is 500 divided by total daily dose of insulin. That will give you the carbohydrate count. Now, if that's the case, the food tray that is brought to the patient has already been checked in the kitchen and put in the computer as to what all it contains. What nurse's job it is to pick up the food tray from the patient, and when it picks up, she writes what percent of what food was taken and what is left behind. Based on that, all calculation is done by the computer and told how much insulin to be given based on the ratio that we have placed there. So that way, carbohydrate counting is very helpful. But it is helpful only in situations where there is established structure of determining how many carbohydrates are happening. You cannot rely on carbohydrate counting by every nurse and every patient, etc. It has to be a structure that has been established. Very briefly about 3 other things over the next 2 minutes. Non-insulin therapies. It has been shown possibly better glucose control when we use GLP-1 receptor agonists with insulin while in hospital. Possibly less episodes of hypoglycemia when GLP-1 receptor agonists are used while in hospital. So it appears that there is some benefit of using these agents while in hospital. We don't use SGLT2 inhibitors in hospital. We use them only in stable patients in rehabilitation ward or those on long-term care, etc. Otherwise, we, as a standard, use only insulin. A few words about continuous glucose monitoring. Data implies that if you use continuous glucose monitoring, you recognize more hypoglycemias than existed. So it appears there is more hypoglycemia, but there's just more recognition of hypoglycemia and possibly less hyperglycemia. And in those persons who are using CGM at home, it is reasonable to continue using CGM in hospital. We don't start CGM in hospital in any of the continuous glucose monitoring in hospital. And about insulin pumps, it is recommended that those who are using insulin pump at home, we possibly could continue in hospital. And American Diabetes Association now says that even automated insulin delivery can be continued in hospital. Okay, move. That's what we follow as well. There has to be some strategy. What if pump fails? Then where do we go? There has to be some strategy of finding out how much basal insulin needs to be started if pump fails or pump stops or patient becomes unconscious, etc. And these are some strategies that have been shown here. All those are in the pump settings. One can see and one can calculate how much the doses are going to be. So in summary then, we should check glucose fasting and before meal in every patient who comes to hospital, if required at bedtime as well. We do not use insulin injections based on glucose measurements at different times before or after eating, etc. We should start lower dose in those who are prone to hypoglycemia and those who are prone to develop complications from hypoglycemia. We should use carbohydrate counting, but only if there is a system that has been established to calculate the doses. We should consider non-insulin therapy in stable patients, especially DPP-4 inhibitors, GLP-1 receptor agonists, and pump and CGMs can be used in hospital, but only if the staff is trained to use it and patient is conscious and can self-manage. Thank you very much.
Thank you, Dr. Shah, for that informative talk. May I introduce our second speaker, Professor Thilak Weerarathna, the Dean and Senior Professor of Medicine of Faculty of Medicine, University of Ruhuna. Professor Weerarathna is going to talk on cardiovascular risk in diabetes. Over to you, sir.
Thank you. Let me first apologize for some changes in the topic. Actually, this should be the original one. It's a prediction of CVD risk in diabetes, addressing the unmet needs. Now, at the beginning itself, let me say that we as doctors sometimes have to do predictions. Not that we are going to be soothsayers or fortune tellers, but what patients expect us is what is going to happen to me with this report of cholesterol of this much or ECG of this abnormality. At the view, like it or not, you have to tell something. Yes, you have a risk of developing a heart attack or any adverse cardiovascular event within the near future, or it is remote. So in the next 20 minutes, I will take you through about 30 slides, hoping to make you enable to implement an evidence-based practice to screen patients with diabetes with no symptoms of cardiovascular disease. In doing so, I'll have to first address the burden of cardiovascular disease in diabetes. When I refer to diabetes, it is more or less type 2. As you know, prevalence-wise, the burden-wise, the country like us are facing the burden of type 2 more than type 1. But to some extent, type 1 also can be included here with some exceptions. Then I will review the contemporary CVD screening tools in diabetes, basically diabetes and non-diabetes both, but what specific to diabetes also have come out in the recent past, and my role is to predict the future. Now this slide shows very recent data, deaths from diabetes by age. This is a global one at the top and the Sri Lankan statistics at the bottom. So we can see, despite all advances, globally, the deaths due to diabetes is on the rise. Of course, the story in America and Europe may not be this bad. But when we took all data globally, this is what it reveals. You know, I think there's a recent article from UK showing that deaths due to diabetes due to vascular causes are on the decline. I'm sure that this case is so in North America as well. But when it take all the global figures, we are not winning this battle of deaths due to diabetes due to vascular disease is on the rise. And what is more startling is that the age group between 50 and 69 also on the rise. And more than 70 is worstly affected. So with this background, and this slide again shows something different from the previous one, some different information. What you can see is that in the females, this burden of vascular deaths in diabetes is more. Females, unfortunately, have higher burden of vascular burden due to diabetes based on the data, life expectancy. The black part of the graph shows the vascular deaths. So you can see the burden is more among the females. Now this slide summarizes all complications of diabetes. On your left hand side, you have the macrovascular disease, and the other side, you have the microvascular disease. To start with, the coronary artery disease, and that is the one that causes highest number of deaths, and then came the heart failure, then come the peripheral vascular disease, then comes the stroke. So the macrovascular disease in diabetes is really something that very little solutions have been found against over the last couple of years. So we need to have better prediction tools to reduce deaths and morbidity due to macrovascular disease in diabetes. Type 2 diabetes is a major risk factor for cardiovascular disease as evidenced by so many meta-analyses and so many trials. And this is a fairly about more than a decade old study, but it shows about 2 times higher risk of major cardiovascular events in patients with diabetes. So with that, I conclude this slide as well. And this slide, why I bet, even though it's about more than 25 years old, this is the slide where Steve Hafner in 1997 showed that people with diabetes without previous MI has the same risk of developing a new MI as those who have already developed a MI without diabetes. So what you can see is the ring area, these 2 populations have almost the same risk. And with this finding, of course, they went on to say that diabetes is a cardiovascular equivalent and so on and so forth. Although there was opposition to that came subsequently. But the debate goes on. Let the debate goes on. But the truth and the bottom line is that as doctors, we haven't had a much improvement in vascular deaths in diabetes over the last couple of decades. So we need to find solutions for that. What factors are known to increase the CVD risk in diabetes? What is specific to diabetes? We all know the CVD risk in any individual increases with age, increases with LDL cholesterol level, increases with other metabolic syndrome, chronic kidney disease, and the newer additions of LPA levels and so on and so forth. This is in general population. When it comes to diabetes itself, the duration of diabetes more than 10 years is considered as a high risk group. When they have albuminuria, when their eGFR falls below 60, when they have peripheral artery disease as manifested by ABPI of less than 9, and also retinopathy and neuropathy also now considered to be some confounders to cardiovascular risk in diabetes. So when you have to develop some risk scoring tools, we need to include all this into that tool in order to it to be valid. So contemporary cardiovascular risk scoring tools, you can divide them into two: CVD risk scores and the non-invasive tests. So CVD risk scores are general risk scores which can be applicable to diabetes because there is a provision for diabetes or not, and there are newer ones coming diabetes specific. And when it comes to non-invasive tests, there are so many. I will just brief in the slide soon. But there are two tests have come as potentially useful in the clinical setting. Those are coronary artery calcium score and the coronary CT angiogram, CCTA and CAC. Of course, there are others, but because of the cost and the availability, I will not, and myself not being a specialist in cardiovascular imaging, I am a specialist in internal medicine with an interest in diabetes, but I thought I am not the best person to tell about SPECT and even the CCTA. So I will brief in the perspective of an internal medicine specialist. Now, what you see here is the main ASCVD or CVD risk scores. The first two widely used are in general population, and the lower two are diabetes specific tools. And included variables are given more or less the same, but they have some minor variations. And how they predict is by giving the 10-year risk of developing an event. When it comes to less than 10, it is called low risk. 10 to above 10, it is moderate to high risk. Above 20, definitely high risk. And now there are very high risk groups also coming with this. So just to give a brief idea about these scores and their variables included. And based on this, professional organizations come out with the risk categories. Mind you, however united in one health, one world we are, people differ in their opinion. When the Europeans come with some risk category more than 10, Americans come with almost little similar or little different. Now to add to the fray, the French Society of Cardiology also has come, that's the third column. So they are more or less the same, but don't want to put into the same one group. Just to show how united we are in this world. So Europeans, Americans and French have different categories, but if you see them in general, less than 10-year risk is considered low, more than 10, moderate to high, above 20 is very high. That is it all. But there are, other than not having a unity much, there are pros and cons. Some of these risk scores have not taken into consideration the diabetic specific things, like what we see is the duration of diabetes, EGFR, HbA1c level and so on. So Europeans have recently come out with solution in the 2023 that is a score 2, a score which is specific for diabetes. They have validated across Europe in a fairly high number of patients. And they now recommend in the ESC 2023 guidelines to use this as a screening tool for diabetes patients for CVD risk prediction and for subsequent testing. For you first screen at a population wise with a score. In a public health wise, that's a good strategy, cost effective, because you don't have to send the patient to an expensive investigation. First, you screen, and if the score is high, then you decide whether the patient needs further testing with a CAC or CCTA. So, it is included in the 2023 ESC guidelines. Now, you have so many scores. Now, this article published in 2022, I'm sure now they have in 2025 maybe, scores. Major 22 scores up to now. Now, do these 22 scores tell the same story? Now, The conclusions of this research, they evaluated 22 CVD scores in a representative 168,000 UK-based individuals with T2DM without pre-existing CVD, AF or heart failure. But their conclusions were CVD restriction scores could not accurately identify individuals with type 2 diabetes who experience CVD event in the 10 years of follow-up. They may be good as a population-wise, but as an individual patient, when a patient comes to you with a report with a so-called borderline ECG, with some non-specific cardiac pain, with a high LD level and so on, we are not faced like a Minister of Health facing whether the patient, all patients with diabetes should be prescribed statins also. We have to give a solution to that patient. So when it comes to clinicians, we need to have a better tools to predict cardiovascular events in diabetes. In that sense, we need to rely on tests, either CAC or CCTA. Now this slide is the one that I mentioned earlier. These are the currently available cardiovascular imaging tools for cardiovascular disease or coronary artery disease. Starting from the SPECT, single photon CT and a stress echo and cardiac MRI, CCTA and coronary artery calcium. I have just Googled because at least first one is not available in this country to my knowledge. But others, there's a potential we can do stress echoes, our cardiologists I am sure. Cardiac MRI is available only one place, I was told. CCTA is available more than in 10 hospitals. And the CAC available in about 2 or 3 hospitals in the private sector. And the costs are also given here. Out of them, only the CCTA and the CAC, I am going to elaborate on the research data. What is CAC? It's a gated non-contrast cardiac CT. It will give you a calcium level deposited in the heart, especially the coronary arteries. It gives you a score. No plaque, that is 0, 1 to 10, minimal, 10 to 100, mild, and so on. If it is more than 400, it is severe calcium score in the heart. That is what it is. Here again, research has gone into the validity, the usefulness of CAC in predicting cardiovascular disease in diabetes. So, this study, specifically in patients with diabetes, they looked at the value or validity of this. They first see how useful is the score. Then they added the coronary artery calcium to see what added benefit can you get by adding the coronary artery calcium with this score. And they found that addition of the coronary artery calcium score to the score gave a better area under the curve. But if you can see the first half, even when it comes to only the score wise, the highest 2 quartiles tend to emerge in time. And the third quartile used to come up. So that means this high risk only on the score does not necessarily mean that the patient had a high risk. But when it comes to calcium scores, it is a different. Calcium scores, they really identified, they are not coming together at any stage in the second slide. Just to say that investigation has a better value. Here again, this slide, the Korean patients with coronary artery calcium less than 10 and more than 10, their risks are higher when it comes to 10 years of follow-up. So based on this, the guidelines have come to use the coronary artery calcium in the decision making. What to do when they have more than 400? Definitely that is in the red group. When they are less than 10, that is green. You don't have to do much. But in between, you have to exercise caution and take individualized decisions. Let's go into CCTA in the next 3 minutes. You know, CCTA is emerging as one of the widely used tools. One of the intervention cardiologists in Colombo told me that more than 50% of the doctors in Sri Lanka have undergone CCTA. Sorry if I have done it. So as a screening tool, asymptomatic. That is the situation. Now CCTA that is the CCTA that we all do. Now there are advancement of the CCTA. They can look at the plaque. They can look at the certain physical signs. They can predict whether the plaque is highly vulnerable or not. They can predict the score and say that whether this plaque is going to rupture soon or this is a stable plaque based on certain features. Now AI has come into the picture, machine learning. So based on this, certain prediction tools, algorithms have been made where once you undergo CCTA, somebody can predict whether it's in very high risk or high risk. And this transform trial, is the one that looked at the two arms. One arm, only the CCTA and the conventional treatment. Other arm, CCTA findings, helped by the AI verifications, enable the decision making, whether they are helpful or not. So now, clinical utility based on this have come out. And I think more than this slide, this is the slide that I want to keep in mind when you go back. You can categorize the risk into low CVD risk, moderate risk, high risk or very high risk based on the score and the CCTA findings. And whether this patient should go into the next level test is summarized in this slide. So as it's less than 1 minute, the take-home messages as increased CV burden in diabetes compels the need to cost-effective and safe screening protocols. There's no doubt about it. Studies reveal that relying only on the score underperform the predicting value of the score. And some silver lining is in the CCTA aided with AI is proving to be the promising CVD risk prediction tool in the future. So I hope there will be more advanced AI-directed algorithms to predict somebody's CCTA and give best therapeutic options for individuals with diabetes. Thank you very much.
Thank you very much, sir. Our next speaker is Dr. Vinaya Simha. Dr. Vinaya Simha is a consultant in the Division of Endocrinology and Associate Professor in the Department of Internal Medicine at Mayo Clinic, Rochester. Over to you, sir.
Thank you very much. Thanks again. So a little while ago, I was trying to talk to you about novel lipid-lowering therapies, but then this time around, I don't want to be seen as a drug pusher. So it's not just about new drugs. So we'll also talk about new technologies. So there are two broad objectives here, and then they're not necessarily going to be in this order, but it is to understand the role of these novel glucose monitoring techniques and also the novel insulin delivery techniques in the management of patients with diabetes. So let me start with a story. So this is an unfortunate story of a patient who had pancreatic adenocarcinoma, and then he underwent total pancreatectomy. And that was almost 4 weeks ago, had a prolonged hospital stay, as happens in most of these patients. There were multiple complications, but somehow he tided through all of this. After all, this was the Mayo Clinic. Okay? And then so he's now ready for discharge. So his nutrition is mainly through this PEG tube. So this he has a jejunostomy tube. But then he's also eating a little bit. And then he's continued to receive nocturnal tube feeds as well. And this is what he will be going home on. So he's going to get this formula feeds, which is basically like a high fructose corn syrup that is pumped into his jejunum. He does not have a pancreas. He does not have a stomach. And then, so we are trying to manage his diabetes. So what we were using was this NPH insulin. I believe that is fairly commonly used here. I was talking to some of your endocrine colleagues. So you call this as isophane insulin, I'm told. So this is this isophane insulin. He was on 6 units 3 times a day, plus he's also on some supplemental short-acting insulin. And to top it all, the poor chap did not even have diabetes to begin with. So he has no inkling about how to, he's just beginning to learn. But then he was never dealt with blood sugars and complicated insulin regimens and all. So he was very healthy till all of this happened. So, and then his BMI is fine. Now, what is the optimal management of his diabetes? So this is where he's all ready to go home. So should we put him back on this insulin, like this isophane insulin 4 units, and then give some 10 units later on, or give him a basal bolus insulin regimen? Dr. Shah was talking to you about how to do this. So with the glargine insulin, half of that, and then give another half with his meals. Or should we do these more novel technologies, whether it should be a sensor-augmented pump or a closed-loop insulin pump and so on? Yeah. So I don't really want you to vote, but then just listen to what all we did. So we did all of these things in series. So we first had him on this isophane insulin at night, and then had him on a little bit of insulin. And look at how bad we were doing. So these are his blood sugars. And as you can see, I mean, you don't have to read those numbers, but you can see how it's all over the place. And then we thought, well, why don't we actually add a sensor? This is this continuous glucose monitor that people wear. So this was a Freestyle Libre continuous glucose monitor he wore. And we haven't done any better. So again, you can see that the blood sugars, so we want all the blood sugars to be here. This is the nice range that we want the sugars to be here. And it did not really help. So sugars are still high and sometimes low. So it only helped show better what a poor job we were doing in terms of his diabetes control. And then finally we thought, well, why don't we start him on a sensor-augmented insulin pump? So this is where he is getting continuous insulin infusion. So that's what this will show here. So this is the insulin infusion that he gets. So he gets a higher rate of infusion at night to cover his nocturnal tube feeds. Oh, the pointer doesn't work. Oh, sorry. Oh, thank you. Thank you for letting me know. Okay. No, I'm not sure. Oh, now it probably works. Oh, okay. So here you can see this. So this is the insulin infusion, which is like we're giving a different insulin infusion during the night, different insulin infusion during the day, but still the sugars are not all that great. Now, all this is a prelude to what finally I think kind of fixed the problem. And that was this closed loop insulin hybrid. So what the closed loop, not this one, very good, sir, thank you. So what the closed loop insulin hybrid does, this insulin pump, so basically it will sense the real-time data it gets from the sensor. Based on that, it adjusts the insulin infusion rates. So when the sugars are going up, it will give you more insulin. When the sugar is going down, it interrupts the insulin. That's what you see with all these red blobs. That's when the insulin delivery is interrupted. So clearly, as you can see, I mean, I don't want to speak too much. So the picture tells the whole story. So going back to what we were doing here, sugars are all over the place. And then with the sensor augmented insulin pump, it's a little better. But with the hybrid insulin pump, so you want everything to be in the green. Okay, so and here you can see there's much more of the green. I mean, we're never going to be 100%, but then we're doing way better. So this is by way of an introduction to the utility of augmented or rather closed loop insulin pump therapies. A brief look at what these are. So the hybrid insulin pump, so essentially what they have is this. So there is a continuous glucose monitor. This continuous glucose monitor measures the interstitial blood glucose, and in real time, it provides this data to a controller. And this controller may be either housed within the insulin pump itself or with an external device, a controller, which then controls the pump as well. And that will depend. The pump itself can either be tube, like it has a tube. So basically it's a syringe with a motor. That's all. There's this tiny little syringe here, which constantly keeps pumping the insulin either through a tube or even without a tube. There are these patch pumps. So that's what we have in essence. So it is, so they try to call it as an artificial pancreas, and that's what the pancreas does too. It senses the glucose and releases insulin. So here we have a pump which also gets information on the glucose and releases insulin. So in theory, that's all it is. So in practice, so this is what we have. Again, I have no idea what all is available here. So I won't spend too much time on the nitty-gritty details about this, but at least in the US, these are the three pumps that we commonly use. So one is the Medtronic pump, and then the other is the Tandem T-Slim pump, and this is the patch pump, the Omnipod. You have these, I suppose, hopefully. Okay. So these are the ones which, I mean, even if you don't have, you'll get them soon, I'm sure. So these are the ones that we use. And then Yeah, so if you don't really have it, then I don't think I should waste my time giving all of these things. So just know that the Medtronic, so there are these different series, the 670s and 770s, 780Gs. And then we have the Tandem with the Control IQ. And then we have the Omnipod system. So these are the main 3 pumps which are commonly used in the US and in Europe, so which have been improving the care of patients with diabetes. Now, some more of salient features, just to kind of tell you how these pumps work. So this is what the pumps do. So you can set a target glucose. So it will keep adjusting the insulin mainly to get to this target glucose. And this target glucose is a little different. So all of them have their own proprietary softwares. So the Medtronic has 100 milligrams per deciliter, Tandem it's 112.5 to 160, and this is the Omnipod. And you can customize it a little bit. So in some of these, you can customize the target glucose, and you can do it at different times. Like with the Tandem, you can tell the pump, I'm sleeping. So when it is sleeping, then, it tries to get the blood sugar between 112 to 120, as you can see here. And then similarly, when you are active, you are at a higher risk of low blood sugar. So you can tell it, look, I'm exercising. And then the pump will try to keep your blood sugar now between 140 to 160. And the same thing, you can do it with the Omnipod as well. So there are some subtle differences in the target that you can set this pump to be. In addition, the basal insulin itself, of course, there's nothing like basal here. So it is like a series of micro boluses which are delivered every 5 to 10 minutes based on the real-time CGM data. And then in addition to this, it delivers these auto-correction boluses. So it looks at the blood sugars and then say, oh, it's not yet at the target, or it's not yet close to the predicted target. And based on that, it will deliver a micro bolus as an auto-correction. And it also gives the option for the patient itself. Look, your sugars are really high. Do you want to deliver a bolus? So even that is available. And different ones, as I told you, these are all proprietary. So they have their own thing. So the Medtronic will give a target 120, and then it will give you after. First, it tries to ramp up the basal. If that's not delivering it, then it gives an auto correction bolus. Whereas the Omnipod will do it mainly by further ramping up, more aggressive ramping up of the basal rate. So there are different ways in which it tries to do this. What can you do then? Okay, so that's the thing. So when it will automatically set the basal rates and it will adjust the basal rates. So what is the job of us endocrinologists here? Well, we still have some things to tweak, mainly by way of the boluses. So the pumps still, at least most of these pumps, they don't know when you are eating. So the patient still has to tell, oh, look, I'm going to have a meal. And then it will also have to tell them how much insulin is required during the meal. So that typically depends upon how many carbohydrates and how sensitive the person is to the carbohydrate. So the patient has to enter how many carbohydrates, and you as the provider can tweak these things. ICR is the insulin to carbohydrate ratio, how many units of insulin are needed for each carbohydrate gram, the active insulin time, the target glucose temp. So there are a few things that you can still tweak. So once you start using them, so you will know. So it's not completely automatic. So there are some things which are still under your control, but much of the basal rate is automated, and that has been very beneficial. Though I told you that there are pumps which don't do. Now we do have, these were the 3 that we commonly use. There are some other novel pumps which are available which don't even need this carbohydrate counting. So one of them is the so-called bionic pancreas made by Islet. All you need to tell is what is the weight of the patient. You just need to say, oh, I'm a 60 kilogram patient, and that is all. And you put this pump on. The pump will do all the subsequent calculations. And you just have to say, I'm eating now. I'm eating a small meal or I'm eating a large meal. And that is all you need to do. And it keeps learning. So this is artificial intelligence. So which will, like every 3 days, it will learn, oh, I gave this much and the sugar was still not high. Next time it will give you more. So there are these very exciting, promising, novel technologies which are emerging. So this is a list of all the currently approved AID technologies. And then these are the FDA approved ones. In addition, we have this DIY, that is the do-it-yourself loop. So there was a bunch of, these were actually mainly, they were parents of children with type 1 diabetes who did not want to wait for the FDA approval. So they got together and they developed a software for all these automated insulin deliveries. And I have some of my patients who actually do this. So they do this, they use an old hackable pump, and then they use a sensor, and they use the software that will regulate the insulin delivery using the sensor signal. So these are the open APS, and there's an Android APS. So all of these things are available. How useful are they? So I'm just going to do one slide showing you, trying to summarize all the randomized control trial data and also the real world data. Again, it's not like we have very extensive data. So most of this is like short duration studies, anywhere from 3 to 12 months. That's the RCTs. Is about 3 to 6 months. And then the real world data we have for close to a year. Most of the RCTs were a few hundred patients. And then now we have real world data on like 5,000, 6,000 patients. And what they have uniformly shown is an improvement in glycemic control. So the glycemic control we want to look at mainly is the time in range. So since we have continuous glucose monitoring, we now want to look at how long during the day were the blood sugars between, say, 70 to 180, which we think is the sweet spot. And uniformly, there was an increase by about 9 to 16% in the time in range. And this was much greater in people who are already doing bad. So obviously, you can't improve on something that's good. So, and also the A1C decreased by about 0.3 to 0.5%. None of this is like, it's not a quantum leap. So there is some improvement. But really why we are still excited about is this. All this reduction happened without any change or even a reduction in the duration of hypoglycemia. Now, with all the prior trials that we have had on intensive insulin therapies, even Dr. Shah showed you that in the hospital as well, if you're being very aggressive with insulin therapy, the price you pay is hypoglycemia. This is the one time when you can be aggressive with insulin therapy, improve blood sugars without a concomitant increase in the risk of hypoglycemia. So that to me is why I'm really become a big fan of these automated insulin delivery. And then, in the pivotal studies, of course, it's always going to be easy. This is like if there's a nurse practitioner or a research coordinator who looks at the data every single day. And so, of course, there is a lot of help there. But the real world data also seems to be following the same pattern. So that again, I think is very encouraging and reassuring. There are some studies which have looked at the quality of life, and then uniformly the patients report improved quality of life. They feel that the burden of diabetes care is less. The fear of hypoglycemia is less. And the most important thing is they sleep better, and so do their spouses and other family members. So they've actually looked at that. So there is like the parents, they sleep better because they know that their child is not going to get severe hypoglycemia at night. And there are low rate of complications. Potentially they can get DKA and severe hypoglycemia, but at least in the reported trials, this does not seem to be very high. This is what a standard AID report will look like. So once you start using this, so these are all the different things. So it will tell you, this is the time in range, the green bar. It will tell you how long they were in hypoglycemia, high, very high, all of these things. It will give you, these are the glucose metrics. We use something called the GMI, the glucose management indicator, as a better surrogate than the A1C to tell us about how good the glucose control is. It will also tell you the insulin metrics, how much insulin they got, how much they got as basal, how much they got as bolus. So you really will get a lot of data. I think this is way more granular sometimes than we want to do, but I think this can make a big difference in diabetes care. All right. However, I don't want you to go to feeling that everybody should have this AID. So the patient should be motivated. They probably should be on an MDI. They should be able to have at least some troubleshooting skills. They must be willing and able to take on these additional costs. Hypoglycemia unawareness is a big thing. So they probably will benefit from this. And most importantly, there should be a good team, endocrinology support for education and access. So then you should get the ideal patient. This is for the automated insulin delivery. But then, now, why did I even put this up? I don't know how many of you will recognize this. This is actually a screenshot from a movie. The movie is called Scent of a Woman. And the reason why I show this is, so Al Pacino here is a blind guy. And so one of his goals in life was to actually drive a car. So he drives this Ferrari driving blind. Okay, so this is, of course, this young boy who actually takes him, who is his caretaker, is like extremely scared, but then somehow he manages to do this drive. Okay, so it's never fun to drive blind, and that's what happens when people with diabetes, so it's so hard for people to adjust their medications without knowing what their blood sugars are. And this is what we are putting all our patients through, giving them insulin and not knowing their blood sugars. So giving a sensor to everybody will be beneficial, and that's what I want to leave you with. So these are all the continuous glucose monitors, and we have various ones. So this is Dexcom, and this is the Freestyle Libre. And this clearly improves glucose control. So this is data in patients with type 2 diabetes. So what we are seeing is patients who are on an MDI, that is, there are multiple insulin daily injections. And the other one, so these are patients who are actually, so that's the red, and this is the blue, is basically those who are on an insulin pump. So it really doesn't matter. Half of them now continue to do home capillary glucose monitor, and the other half got a sensor. So just adding a sensor, you can see it actually improves the glucose control. That's the blues. Okay, so the solid line is those who are on CG, on MDI, and the other is on the pump. So it doesn't matter. What matters is that it's not the insulin delivery. It is just that the availability of a continuous glucose monitor improves glucose control. It increases the time in range, reduces the time in hypoglycemia. So this is in people with type 2 diabetes. So it's been shown to improve glucose control. And I just showed you the comparison between people on an MDI and a pump. And we've done the same thing in people who are on basal insulin and on mixed insulin therapies. So in all of these people, having a sensor will improve. And it improves this without any change in insulin dose. So it's not like they are now taking more insulin. It just seems to reinforce lifestyle changes and other things. And they've also shown that if you discontinue the CGM, then it leads to reversal of this improvement in glycemic control. So I think it should be offered not just to people with type 1 diabetes, but also to people with type 2 diabetes, certainly those who are on multiple daily injections, and maybe even others. So there are some people who have pre-diabetes where we have given them a CGM, and suddenly they eat better, they exercise better, and their sugars are better. So as I told you, it's very hard to drive blind, and knowing what your sugars are all the time seems to help. So these are the pros. Now, of course, there are some cons. So there's potential expense. And then, some patients can become very obsessed with it. So you should always be cautious about whom you give this to. So there is too much data and alarm fatigue and all of these things that can happen too. So I'll actually end by stating to you what the most recent ADA 2024 standards of care, what they say about the adoption of diabetes technology. So it should be offered to most people with diabetes. Certainly, initiation of CGM should be offered to people with type 1 diabetes early in the disease, even at the time of diabetes diagnosis. We don't need to wait till their sugars are bad and they have complications. And it should probably be offered for adults who are on multiple daily injection or on an insulin pump, even if they have type 2 diabetes, and in patients who are, and it goes on like this. So these were the ones where the strongest recommendations, subsequently also for people on basal insulin, and for other people as well. AID, probably with the kind of data that we have, I think that it should become the standard of care for most young and adult people who can manage this technology. So in them, I think automated insulin delivery would be very useful. All right. Thank you very much.
Thank you, Dr. Simha, for that excellent talk. May I invite all our speakers to the stage? As we've got few minutes left, we can entertain few questions from the audience.
My question is to Dr. Pankaj. During in-ward management of hyperglycemia, patients who cannot eat and drink but who are not in DKA, do you use any sort of what we call this variable rate insulin infusion?
So we do have the standard rate insulin, the fixed rate insulin infusion initially in the treatment of diabetic ketoacidosis. And then once the the patient is not eating and drinking, but it's not the DK regime. So do we all use any sort of the variable, not the fixed rate, any variable rate? Yeah, we use a variable rate insulin infusion for those patients who are not eating, have severe hyperglycemia and subcutaneous insulin treatment is not a good plan, they have hypotension, or the subcutaneous plan is not working for them, or they have septicemia, etc. So sometimes we do use variable rate insulin infusion in that setting. Did I answer your question?
Yeah. So, and the other question is, like, when you do you use a specific a solution for variable rate infusion, like a fixed solution where the sodium potassium rate is adjusted?
No, we have different protocols for electrolytes and that for insulin. Our insulin bag is 1 unit per ml of saline is insulin bag, so 100 units and 100 cc bag, and that is adjusted by separate pump, and potassium and other things are managed independent of that.
Thank you.
Can I ask a question from therapeutics diabetes? Now, continuous glucose monitoring in acutely ill patients. Now, because we being a poor country, and sometimes we come across patients whose fluctuations of glucose inward are very difficult to manage even with infusions. What we have is the infusion pump driven ones. Now, what is the time duration that you can keep in this sensor in, and how frequently do you need to? So can we at least adopt this sensor thing as an inward, where we come across some patients whose diabetes control goes haywire during the infection or whatever, and then we can expect a better outcomes in terms of infection or whatever the thing?
No, I certainly agree. I think that's, so, cost is always going to be an issue. But then these things are becoming quite cheap. So at least for patients who pay, the cost of a sensor is almost the same as if you were using finger stick 4 times a day. So I think that sooner or later we will have automation and the cost should not become so much of an issue. The thing is about the reliability of subcutaneous interstitial fluid monitoring. So there is going to be a lag between the interstitial fluid glucose and the systemic glucose, the venous glucose. In fact, in people who are critically ill, like Dr. Iyer, he only will do arterial blood glucose. They don't even want to do venous blood glucose. They think that capillary glucose they think is not good enough. So there is going to be that issue. So we will never know whether they are good enough in people who are critically ill, who are shock, who are on pressors and so on. But otherwise, the other patients who are not critically ill, so I think Dr. Shah showed that also. So now the ADA even recommends that, yes, we can use a continuous glucose monitor in these people. So we have type 1 diabetics who have even a small illness and then their sugars are all over the place. I think using a continuous glucose monitor in the hospital would be beneficial. There are many hospitals which have done these pilot trials, and then they have shown it to be, they are starting to use a sensor. Not just what the ADA says is, if somebody was already using a sensor at home, continue using it. But now we have some data that even starting using the sensor in the hospital is beneficial. In terms of how often we need to change, by and large, it's about 10 days. So there is one, the Freestyle Libre, which you can use for 14 days. The Dexcom is used every 10 days, you change it. Having said that, there is now something called an implantable sensor, Eversense, which can be used every 6 months. So you just put this in like the NOR plant and other things. So just there's an inserter. So this just goes under the skin and then that's it. And it just stays there. And then every 6 months, you'll have to make a small neck, take it out and then put it back in. So all of these are available. Sure, thanks.
If I may just caution a little bit, I'm not disagreeing and never can disagree with Dr. Simha, but some of these sensors, also I should give another background that sensors are much better than they used to be just 3-4 years back, just 8-10 years back. There is substantial improvement. But large doses of vitamin C, large doses of paracetamol, acetaminophen can be raised at glucose. So one has to be careful in what we are seeing, and especially in ICU, etc. So many medicines, they have never been tested. So one worries about using these agents and where the multiple medicines are going in, what is being tested. Of course, it's a good question. None of these enzymes are absolutely specific for glucose and nothing else in those sensor membranes.
As there are no questions, so we will wind up the session. So I will invite Dr. Janaka to hand over the Certificate of Appreciation on behalf of the Sri Lanka College of Internal Medicine. Dr. Pankaj Shah. Professor Thilak Weerarathna. Dr. Vinaya Simha. May I call upon all our speakers for a group photograph?